Okay, so it's nice to present live to this IAVA iLib joint session and the presentation about statin tolerance and Nocebo Ayman Abdulmajid. Nocebo, we know Nocebo, but I don't know Drucebo. So Nocebo, Drucebo recommendation in statin intolerance, Dr. Peter.
My name is Peter Penson. I'm a reader in cardiovascular pharmacology at Liverpool John Moores University in the United Kingdom, and I'm a member of the International Lipid Expert Panel. And it's a great pleasure to be able to speak to you today about statin intolerance and the Nocebo Drucebo recommendations. It's a great pleasure, and I thank the organisers for inviting me to speak today. Here are my declarations. So to give some background, statin intolerance is a clinical syndrome whereby the adverse effects associated with statin therapy result in discontinuation of that therapy. Statin discontinuation is a real problem, and it's associated with increased risk of adverse cardiovascular outcomes. However, most patients presenting with symptoms suggestive of statin intolerance can in fact tolerate some statin therapy. And it's essential that effective lipid-lowering therapy is used in all patients to reduce their cardiovascular risk. How is statin intolerance defined? Well, numerous organisations, the NLA, the Canadian Consensus Group, the EAS, and others have produced definitions, but I'd like to focus briefly on the definition of the International Lipid Expert Panel, which defines statin intolerance as the inability to tolerate at least two different statins, at least one starting at the lowest average daily dose. It's intolerance which is associated with confirmed intolerable statin-related adverse effects, objective effects, including biomarker abnormalities. It's recognized when symptoms or biomarker changes resolve when the dose is reduced or the treatment is discontinued. And it's characterized by symptoms or biomarker changes that are not attributable to other diseases or conditions or predispositions such as drug-drug interactions or comorbidities. How common is statin intolerance? Well, not nearly as common as many people would estimate. And in fact, a recent meta-analysis of the International Lipid Expert Panel, which included over 4 million patients, demonstrated that when we use the objective definitions, the international definitions of statin intolerance to really objectively identify statin intolerance, the prevalence is somewhat less than 10%. But the risk can be increased by factors such as increasing age, some drugs, alcohol consumption, and high statin doses. And so a number of organisations have begun to recognise the importance of statin intolerance in their guidelines and pathways. So, for example, the EAS Society Task Force has recognised that in the case of statin intolerance, we might use alternative drugs such as ezetimibe and bempedoic acid instead. The ACC Expert Consensus pathway looks at the use of a number of different types of drugs such as PCSK9 inhibitor, monoclonal antibodies, bempedoic acid in patients who undergo demonstrated statin intolerance to more than one drug. But I'd like to focus today on one particular aspect in particular of statin intolerance. And this is the perception of patients often that a drug is causing an effect, when in fact that's not always a pharmacological effect of the drug. And we're very familiar with the idea of the placebo effect, that taking an inert substance can make us feel better. And the counterpart to that is the nocebo effect, that if people take a drug which they expect to do them harm or expect to make them feel harm, then they will often experience adverse events. However, the nocebo effect relates to inert tablets and not drugs. So when we're talking about the adverse effects which people take, people experience when they're taking drugs, which are attributable to the expectation that those effects will occur, we call this the Drucebo effect. We've outlined the Drucebo effect in several papers of the International Lipid Expert Panel. And it's well recognized that the side effects of statins are reported to a much greater extent in open label use than in blinded use. And this is indicative of the Drucebo effect. And so these adverse effects, which are result as a result of expectation rather than as a real pharmacological effect of the drug, are a real barrier to effective therapy with statins. And so this year, the International Lipid Expert Panel has come up with recommendations, a step-by-step diagnosis and management of the nocebo-drucebo effect in statin-associated muscle patients. So this is in no way belittling the side effects, or the perceptions that patients have of their side effects, but it's about enabling optimizing of therapy in patients who suffer adverse effects. So the pathway outlined by the International Lipid Expert Panel relates to the initiation of statin therapy, and I'll show you a little bit later the use of a personalized lipid intervention plan, a PLIP as we call it. And this is really important part of patient education. When we initiate statin therapy, it's important that we identify and address reversible risk factors for statin-associated side effects and abnormal liver function. Therefore, we can address these factors at the outset of therapy, so that patients don't suffer side effects in the first place unnecessarily. Those side effects might dissuade them from taking their therapy in the first place. We then initiate therapy and we follow up. If the patients have no adverse effects, we continue statin therapy and follow up efficacy and safety over time. If the patients report adverse effects, we consider lots of factors such as the history of timing and the severity of the symptoms. And we have an acronym which we call MEDS, which is a generic approach to addressing and dealing with statin-associated symptoms. So M stands for minimize, that we need to minimize disruption to lipid-lowering therapy. E stands for education and counseling, that we need to educate patients about the benefits as well as the risks of statin therapy, so that they can make a patient-centered decision about their treatment. D stands for diet and nutraceuticals, which can be important in the management of plasma lipids. And S stands for the fact that we have to consider symptoms and biomarkers to really get to the bottom of the adverse effects in a really objective way. So we measure creatinine kinase and ALT, and if those are abnormal, then we have a series of approaches that we can take to consider the approach going forward. In cases where the patient really cannot tolerate statin and there are very severe objective adverse effects, then we're going to consider alternative drugs such as ezetimibe and bempedoic acid, ezetimibe and nutraceuticals potentially, or indeed monoclonal antibody PCSK9 inhibitors or inclisiran. If the side effects are less severe, or if the biomarker abnormalities are less severe, we might reduce the dose of statins and re-challenge with a statin after a period of time, potentially a different statin. If there are no biomarker abnormalities, then we use the SAMS clinical index, a very well-validated score, to determine the likelihood of the statin being associated with the side effects which are recognised. And in both these cases, we can use the approach that we call SLAP, an acronym which helps us to maximize lipid lowering therapy in patients who've reported statin associated symptoms. So S stands for switch statin. So sometimes just switching to a different drug might result in a different outcome for a particular patient, perhaps switching from a hydrophobic to a hydrophilic statin. L stands for lower dose. Our meta-analysis showed that statin intolerance was more frequently associated with higher doses of statins. So a lower dose is better. Any statin is better than none. Similar to lower dose, alternate day dosing of statins is one approach which might be used to reduce LDL whilst reducing side effects to the same extent. And P, polypharmacy, adding on of non-statin therapies. So you can read this in detail in the International Lipid Expert Panel guidance, which also contains a detail of a personalized lipid intervention plan. So this is a mechanism we propose to really help educate patients understand the benefits of their statin therapy. And we hope that this will help patients to really take an active role in understanding why they've been prescribed the medicine, how that will affect their risk in a personalized risk score, how they'll know the medicine's working. We hope that this will help patients to reach where appropriate treatment targets and prevent therapeutic inertia, and obviously important aspects of safety and efficacy there too. And so bringing that all together, we've recently made some recommendations for personalized therapy. We think that really person-centered therapy is the key to success. So when we initiate patients on statin therapy, we evaluate the risk of cardiovascular disease, we start optimizing statin therapy, and apart from perhaps removing reversible risk factors, we don't worry too much about statin intolerance at this stage, because we remember and we educate patients that in terms of LDL lowering, lower is better for longer. And the earlier we get patients to target, the better. So we will often use high-intensity statin therapy at the outset of therapy. If statin-associated muscle symptoms occur, we confirm it with the approved definitions. We exclude risk factors where possible, and we exclude the Nocebo Drucebo effects using the SAMS clinical index, the patient the patient-centered education approaches and the MEDS algorithms, and we follow the recommendations in management. In terms of that, if we follow those guidelines, then we think that up to 98% of patients will be able to be treated with statins. That's not the end of the matter. We need to continue to educate patients about the benefits of treatment. We need to make sure that we are using co-therapies where necessary, particularly when we use less than guideline recommended doses of statins, and particularly the innovative therapeutics, and to ensure that our patients reach their goals. And actually, using this approach, at least 95% of patients can reach their goals. So therefore, going back to our background and summarizing, statin intolerance is a clinical syndrome whereby adverse effects are associated with statin therapy and result in discontinuation of therapy. True total statin intolerance is rare. Most patients presenting with symptoms suggestive of intolerance can in fact tolerate some statin therapy. It's really essential to rule out other causes of those symptoms, such as muscular injury or comorbidities. Effective lipid lowering is essential in all patients to reduce cardiovascular risk. We use statin therapy when it can be tolerated. We use non-statin drugs instead, or as well as statin therapy as appropriate. And really a personalized approach is essential, both in terms of the treatment path that we use and involving patients in decision making. Thank you very much for your attention.
Thank you, Peter.